the borders, let us live together. We are one family, united forever. Aye, Mama Africa, Africa for Africans. No African is a foreigner in other African country. No African should ever die in search of decent life in Africa. This is our home, say now we get some more. Let Africa be free for its people. Yeah, we wanna be free in our motherland. Break all the barriers, yeah. And the boundaries holding us apart, Africa must unite, yeah. We unite or we perish, yeah. Aye, Mama Africa, Africa muye. Aye, Mama Africa, now you want we get. Break down the borders, let us live together. We are one family, united forever. Aye, Mama Africa, Africa for Africans. For equality and growth in our continent, Africa, we don't need borders. For inclusiveness and sustainability, yeah, break all the borders. For meaningful contribution in creating the Africa we want, we don't need borders. To iron out our differences as a family, yeah, break all the borders. Africa for all Africa. Aye, Mama Africa, Africa, yeah. Mama Africa. Aye, Mama Africa. Now you want we get. Africa, your name. Break down the borders. Let us live together. We are one family, united forever. Aye, Mama Africa, Africa for Africans. We want Africa without borders. Hey, yeah. Borderless Africa, Africa rising says. Let our people move, remove visa restrictions. Free movement of Africans in Africa. Ooh, borderless Africa. We want a borderless Africa. Hey. Aye, Mama Africa, Africa, yeah. Mama Africa. Aye, Mama Africa. Now you want we get. Africa, your name. Break down the borders. Let us live together. We are one family, united forever. Aye, Mama Africa.
Lara.
Hello?
Yes, go on. Start.
Okay, great. So I'm very excited to have everyone here and that we're getting an audience that is just content-wise to talk about an issue that, affects us, really affects women and girls everywhere globally, but has some particular factors to us Africans here. But before getting into that, Ansel wanted to give some background about the overall women's campaign that we're doing this month. So I'll let her get to that before introducing the wider picture today.
All right, Pan-African greetings, dear comrades, and welcome to this special webinar by the Africans Rising Feminist Task Force. We're very excited to be having Lara, who is a member of this task force, moderate this very beautiful conversation today. And this is coming in very timely in the month of March, which we have dedicated to be dedicated to women. So we're not only highlighting the struggles of African women, but we also are using this month to also celebrate the African women historically and currently that have been, paving the way for us, for others, the strong women in communities who have been leading movements, mobilizing groups, and just doing amazing work in their respective ends. So we're very excited to be having you comrades join us today, and we want to urge you throughout the month of March to join our campaign, which is on the theme Championing Gender Justice. And championing gender justice will simply mean standing up for the rights of women and girls everywhere and ensuring that they are treated with dignity, with love, and with respect in community. So we want you to challenge yourselves throughout this month to be able to do that. Just do it for someone. It could be your neighbor, your sister, your friend, anyone. Stand up for someone, and let's continue to fight for a just and equitable world. So I'm very happy. And if you're just joining an Africans Rising webinar for the first time, Africans Rising is a Pan-African movement of individuals and organizations that work for unity, justice, peace, and dignity. We're present, we have membership in all African countries and in 150 other African or other countries and territories of the world. So we're also in the course of this webinar going to share the link that would allow you to join the movement if you are not already a member of the movement. And let's continue to push for the global work that we do, but most especially our dream of having a unified Africa. So over to you, Lara, for the context, what we're discussing today, but also to introduce the amazing speakers that we have today. I'm happy that we're talking about a topic that many people often neglect, and that of chronic pain and invisible disabilities. And I'm really looking forward to learning from the wonderful panelists that we have today. So thank you, and over to you.
Great, so let's get to it. So the reason that we chose this discussion today is not only is it Endometriosis Awareness Month, but as Ansel pointed out, chronic pain and visible disability, these are things that affect people everywhere, but women and girls are disproportionately affected. And there are specific conditions such as endometriosis, endometriosis, fibroids, a lot of stuff that really put us in a position where we are just dealing with a lot of things silently. And I found this interesting because I work in a lot of contexts that are like with activism and women's rights, but even within these circles, a lot of women don't seem to be aware of how we have these shared experiences and how prevalent it is. So I felt like this was something that needs to be highlighted because while we have lots of great women and girls everywhere who are fighting for causes, they are silently battling their own private battles. So this is something that needs to be highlighted. And in Africa specifically, we have a lot of, just across the continent, a lot of factors that are such as cultural and structural, where we're less likely to, receive some type of care or more thorough type of care. And the organizations we work with are often aren't even aware of this. So I'm excited to really give this a Pan-African perspective. And we have three great panelists today, just from all across the continent. So from South Africa, we have Dr. Christo Manuka, and he is one of the, I'd say, the leading endometriosis specialists in South Africa. And even across the continent, there's still just this huge shortage of specialists. So he will be giving us insight, both a medical perspective on it, as well as kind of highlight what some of the symptoms are. So in case people aren't aware, then I will be introducing Suhaila El Fakaheni, who is an Egyptian medical anthropologist. And she will kind of give more of those sort of cultural, sociological lens and mention some of the factors affecting North Africans and Egyptians. just to kind of give us that more layered view into what's going on culturally and sociologically. And after that, we will be speaking with Elsie Wandera, who is the founder of the Endometriosis Foundation of Kenya, and she is doing great work in trying to connect people with specialists and with support groups and really just raise awareness across the country. So I will be introducing Dr. Benica first, and or he will be leading first to really give a background of endometriosis in a medical sense and just how prevalent he believes it to be in South Africa. So over to you.
Good afternoon, everyone. Thank you very much, and thank you very much, Lara, for the invitation. This is something very close to my heart and something I've been working on for many years. So the prevalence, as you've mentioned, and we quote this often, 1 in 10 women will have endometriosis. That's a phenomenal amount. I mean, it's scary that there are so many people and we don't get to everyone. So I think what you're doing at the moment and this drive is so unbelievably important to get it out there that endometriosis is very prevalent and that we need to help women and young ladies. So maybe then if I can start, so what is endometriosis? It is the lining of the uterus is called the endometrium. And that's a very unique type of cell that thickens and then it bleeds off every month. Now, if a type of cell starts to act like the endometrium and it's elsewhere, so it's outside the uterus, then it's called endometriosis. And what happens with endometrium when a woman has a menstrual cycle, the menstrual blood goes out the vagina and obviously out. When a cell that's inside the abdomen or an ectopic position, this menstrual blood can't go anywhere. So it forms a lump or a nodule, and it's fundamentally an inflammatory process causing pain. So people with endometriosis will present primarily with pain, be it menstrual pain or chronic pelvic pain or pain with intercourse or pain with bowel movement. So pain, and then obviously infertility because of the inflammatory process and the scarring that happens. So if anyone sees a woman, young lady with bad period pain or chronic pelvic pain, that person needs to be investigated for potentially endometriosis. Yes, what else? The prevalence and the presentation.
Yes, so what I'm wondering about specifically is that sometimes there are, women who or young girls who are dealing with like a textbook example of endometriosis, like the heavy periods or specifically helping or happening when they have their period, widespread pain, lower back pain, very often in the onset of puberty, these things that are just supposed to seem like a classic sign of endometriosis. But despite them meeting this, standard definition that is, common among gynecologists, I believe, why is there still that struggle to get a diagnosis? I hear from girls and women about how they talk about this and they're brushed aside. So within the medical community, why is there still a lack of awareness?
I wonder, and it boggles my mind that that in the medical fraternity, people are not aware and they're not sensitive. And it's also, a cultural thing. I think that often young women, ladies, have been made to believe that it's okay to have bad period pain, and it isn't, So it's definitely the medical fraternity's responsibility to be aware and to be sensitive to that. And also, drives like this to make patients aware or people aware that it's not okay to experience bad period pain or chronic pelvic pain, and if they do, to seek help. But yes, I agree that even in the medical fraternity and people like me that work with this every day, that patients don't get to me. They get fobbed off. They go to doctors and medical professionals, and they don't get the appropriate care, and that's unfortunate. And
Okay, and just to kind of to stop the cycle in its tracks, or to stop it escalating in patients going all over trying to look for the right doctors, where should they begin and what signs should they look out for to find the right doctor? Because I also hear about concerns where they visit gynecologists who kind of brand themselves as endometriosis specialists, but when they talk to them, they hear all these myths about how they should just get their uterus removed, or how, it's all in their head, or just all sorts of things that just aren't medically sound or up to date. So in order to prevent them from, going down this, really hard path, how do they find qualified specialists across South Africa?
yeah, and across the world, it's
Yeah.
unfortunate, that people they brand themselves as specialists and experts, and they're not. And it's difficult. And you know what? There's unfortunately not an awareness, but there are organizations, especially in South Africa and the world, endometriosis groups. And I think social media should help with that. But it's very difficult to judge the quality of the care, because even being part of a group might not make you a specialist, and just because you belong to a group doesn't make you a good surgeon. So it's very difficult, and I presume that word of mouth and social media is helpful, but it can also be quite dangerous, because there might be a personality clash, and then people might call people out. Yeah, so it's difficult, and I appreciate that. And I often ask patients of mine, put out the word that there are help. You can get help, and you can get very sensible help. But I appreciate it's difficult sometimes to judge the quality of care, because it's a personal thing, I suppose.
Okay, and when you meet patients, I'm sure it varies, of course, according to case. How do you know like how to approach the condition? What are like the standards considered these days? Do people talk about going straight to excision surgery? Do they try hormone therapy? How do you kind of lead the case when they sort of present it to you?
I don't think that surgery should be the first port of call.
Right.
I think, I mean, not something like giving a lecture, but a patient needs to be examined appropriately with care and sensitivity. And an ultrasound scan transvaginally is often appropriate and quite sensitive. But as you know, and I think we all do, that endometriosis is traditionally the diagnosis is made with histology. And the scary bit, I think, in terms of endometriosis, is that the extent of the endometriosis and the amount of pain or disability is not equal.
Yes.
So in any case, so a patient needs to be examined with care, and depending on the extent of the symptoms, be managed and be it appropriate, maybe hormonal suppression, but also a lifestyle approach. There's lots of information out there with diet and alternative therapies, which they've all got a place. And then depending on improvement or not, surgery should be an option, potentially, and definitely excisional surgery in a multidisciplinary team with excisional surgery, and then the follow-up care, because your job doesn't stop when you've done the surgery and you've given a patient a handful of drugs. So I think the follow-up care in a multidisciplinary approach with a therapist and pelvic floor physiotherapy and a pain specialist. So the approach should be quite wide. And what I think is important, there's not one size fits all, that the treatment should be tailor-made to the patient and whatever that patient's needs are and will be. And it can be potentially lifelong. And that's worrying.
Okay, no, I think that's a good thing to keep in mind because I do sometimes see this language in groups and in these circles where they talk about curing the condition. But from what I understand, the way to approach endometriosis is the way you would approach some other lifelong conditions like diabetes or just other sort of chronic things that you manage. So I do really appreciate you pointing out pelvic physical therapy because I've heard that these days in South Africa, there are more and more clinics that are dedicated to helping women who experience pelvic floor dysfunction because of endometriosis.
Correct.
And I also appreciated something you mentioned about how the stages don't really directly correlate with the degree of pain. So does that mean, just to clarify, someone with stage 1 pain might have more pain than or someone with stage 1 might have more pain than someone in stage 4 endometriosis?
Absolutely. And that's the scary bit. And that you cannot, and it leads to the question, why do we make use of stages? It gets to be an academic discussion. I think you have to approach the patient purely on the symptom complex. And however the patient presents needs to be respected and appreciated, and that patient needs to be managed as such. To argue that a patient with stage 1 endometriosis will have very little or minimal pain and will not potentially battle with infertility is completely incorrect. So, it's an individual thing, and correctly, as you've said, a lifelong condition potentially, and managed and handled with care and sympathy.
Mm-hmm. We do have a question that's being asked now in the chat. Someone is wondering if menopause ends endometriosis. So can you expand on that?
Yeah, no is
Yeah.
the shortened answer. The question, I think, often what causes pain? Now,
Yeah.
I've mentioned earlier the inflammatory process, but often it's the scar tissue caused by chronic inflammatory processes. And for the same reason, incorrect or inappropriate or aggressive surgery can cause pain because it causes scar tissue.
Yes.
So, and that's getting back to what you mentioned earlier, Laura, that not everyone is an endometriosis endoscopic expert, and a surgeon should be hypersensitive and respectful to tissue, and not just excise tissue, because that in the long run can cause more problems. So, getting back to your question, will endometriosis stop the disease? No, not at all. Definitely not. And endometriosis is not just because of estrogen. It's actually the dysregulation of hormones, and way more than just estrogen or progesterone or testosterone or any one of those.
Okay, and what I also often hear is this is very common, I think, both in South Africa and really still across the continent in Egypt. I hear this a lot as well, where they tell patients to just get pregnant and that will stop the symptoms. So where does that come from, and what's that about, really?
Yeah, it's completely incorrect and it's wrong, and there's no basis to that statement. I think philosophically, what happens when a patient should a patient with endometriosis get pregnant, then we're happy.
Mm-hmm.
But if a patient gets pregnant, the uterus tends to grow, and often as the expanding happens, there's a breakdown of scar tissue. And that might, in the long term, or at least short or intermediate term, cause some relief and pain.
Mm.
But no, pregnancy doesn't cure the disease at all. It's a complete misunderstanding of the condition.
Yeah, I know. I think really what I don't hear talked about in these contexts is that even if sometimes because it's affected by hormones, there might be like a pause in the symptoms occasionally. That doesn't really indicate that things are getting better. And if a woman is already experiencing pain, you mentioned physiotherapy, which, of course, is to treat the muscles. I can't imagine, adding pregnancy to someone who's already dealing with muscle issues is something that should just be taken lightly. So that is also a part that I don't see highlighted enough about this. So yeah,
Correct.
I think it really does go back to that. We do have another question in the chat where they're asking, what's the difference between fibroids and endometriosis? So could you elaborate on what the difference is, as I believe they're very different?
Completely different condition, completely different disease. And the basis of the two completely different. I mean, fundamentally, a fibroid is a muscle growth in the uterus. So you can get fibroids elsewhere, but that's pretty much unheard of. Whilst endometriosis is a fundamentally an ectopic growth of endometrial type tissue. There is, however, a crossover with endometriosis and adenomyosis, whereby the endometrium grows into the myometrium, the muscle layer of the uterus, but not fibroids. So completely different conditions and managed differently. There are different options in terms of treating fibroids. However, a fibroid can be misdiagnosed for endometriosis in that the patient can present with heavy, painful periods, and then, or the other way around, in that you might think it's the other one and not necessarily endometriosis or myofibroid uterus.
Thank you so much. You also mentioned adenomyosis, and I've heard of it being like the evil twin sister of endometriosis, is how I often hear it phrased. So I think it's important to discuss what that is and how that's treated because it really feels like it goes into the background because endometriosis is more commonly known. So could you tell us more about endometriosis?
Okay, so adenomyosis is whereby the endometrium essentially grows into the muscle, the myometrium of the uterus. And notoriously, you get these enlarged uteri that it's a floppy uterus, and that presents with heavy, painful periods. And it's exceptionally difficult to manage these adenomyotic uteri because surgery is not particularly effective. And so medical management tends to be the mainstay of treatment, and usually a hormonal. And that might have by itself a whole host of concerns and problems.
Okay. And you mentioned earlier that when a patient goes to a doctor who isn't quite a specialist in the disease, they can often worsen symptoms, whether it's because of the scar tissue or I've heard stories from women about how even they've had cases where their nerves have been, kind of nicked or just really just affected in a way that puts them in with worse symptoms, basically. So is it a better idea for sometimes what I hear is women they rush to just go to the nearest doctor. So is it better for them to just treat it conservatively or just try to seek out pelvic physiotherapy or other sort of non-invasive treatments until they're able to get to a specialist?
No doubt. I think, and I've mentioned it earlier, that conservative treatment by far is the appropriate sort of course of action initially. Surgery should not be the first port of call. Surgery should not be the first thing that you think. And inappropriate surgery is absolutely, utterly awful because you can do more damage than good. So if a patient has been managed initially conservative and that fails and there's no improvement in the quality of life, then it might allow that patient to get to the right medical caregiver and ultimately a better quality of life. I think important, and that's where people like me have been canvassing for years, that your index surgery, so your first operation, is more importantly the one chance that you can get appropriate surgery with the least amount of complications and potential side effects. So if it's performed by the right person then and appropriate tissue handling with respect to tissue, then chances are your outcome will be best.
Okay, so just because this is such a complex disorder where you really need to look at the full picture, before I move on to the next panelist, what I want to kind of leave with here is basically any sort of chronic pelvic pain where we don't know what's happening. If it lasts more than a couple of months, from what I understand, like that's already like a red flag for endometriosis, because even if it doesn't show up in scans or with ultrasounds, that's really the hallmark of what endometriosis is that it's kind of invisible or can most often only really be diagnosed through surgery. So just having any chronic pelvic pain, that's already a sign that it needs to be checked out.
Absolutely. And I agree. And you need to get to the right person and conservative management. And obviously, other pathologies need to be looked at, and bowel and bladder and hips and so forth. So it all needs to be examined and assessed, but then the right gynecologist should manage this person if it's indeed endometriosis.
Okay, thank you so much. That's very useful to understand. And when you mentioned about support groups as well, I think if women just talk and see other people and talk to them about their experiences and do their own research, they can kind of advocate for their health with more knowledge, and that really helps put their minds at ease.
Great. Thank you very much.
Thank you so much. And yeah, now I'll be speaking with Sohaila El-Fakahani, who is going to be giving us her perspective from Egypt. It's a different perspective. It's a medical anthropologist's point of view, which is something that I think a lot of people aren't aware of, that there is an entire really area of research and study that looks at the cultural and social factors that are related to, just treating your health and treating conditions. And as someone who is from Egypt, she's also aware of kind of the cultural barriers that exist while trying to get treated. So, yeah, Sohaila, I'd love for you to just introduce more about the work you're doing and tell us how you started your journey with
Of
endometriosis.
course. Hi, Lara. Hi, everyone. Thank you, Dr. Christo, for the great conversation. I wish we had you in Egypt as well. We need one of you in each little city and village and community.
Yeah.
Thank you, everyone, for being here, from the panelists, and thanks, Lara, for all the organization. My name is Sohaila Fakahani. I'm a medical anthropologist. I'm a PhD student at the University of Copenhagen, and my research's title is From Endo Warrior to Endless Warrior, on endometriosis and the lived experiences of Egyptian women. My focus for the research derived from a very personal experience with endometriosis since I was 10 years old. That I realized when I was in my 20s. And a lot of the conversations I'm trying to keep having is with women who have so many different aspects in their lives, except for their being misdiagnosed. They're facing structural barriers. They're facing a lot of stigma and a lot of presumptions about their cases. So I'm not just studying endometriosis, I am living endometriosis, and I come from a family of 5 women who have endometriosis. So my own struggles with the diagnosis and like the normality or the normalization of pain in the culture I grew up in, which is Egypt. I've been born and raised here my entire life. Has led me to realize that it wasn't just a medical issue, it's actually a very, very tightly and directly a social one. So my look wanted to be, I wanted my look to be more biocultural rather than heavily biomedical. So we're trying to look at how women deal with this in a way that makes sense and is connected to their own lives and struggles. And back to even Dr. Christo's point about 1 in 10 women have endometriosis, or the number which is shocking, Yani, that we see. It's a staggering statistic, 120 million women. I'm still very interested in how this number is counted when women do not have the access, when women are not counted, when women do not get the surgery for the protocol or the gold standard kind of confirmation. So yeah, that's me in a very small nutshell. I also work on sexual and reproductive health and matters generally in the entire Middle Eastern North African region. I've worked on Lebanon, I work on Syrian refugees, and I work in Egypt as well.
Yeah, and as someone who's also Egyptian and has endometriosis, I really kind of agree with a lot of what she's saying and have seen it firsthand. And about the 1 in 10, that's also something very interesting to think about, where it's already so common and it might be even more common than we think, because I know that it's very common with women here that they don't even visit a gynecologist until they're trying to get pregnant. Like it's kind of considered a bit of a stigma in a lot of circles. And one of the things that I'm going to be discussing with Suhaila anyway is the structural and class aspects, where a lot of people, when they think of Egypt, they think of, the center, Cairo, where everything is bustling and everything is happening, and the access is a little bit more just easy to see, basically. But we have villages and we have rural areas where we don't even know what sort of treatment a lot of women and girls are getting, where we talk to them and have some idea, but the entire scale of it is probably very hard to actually see. So that is actually some of what I want to talk about, because the structural barriers are very much here and it's hard to see just how far it goes. So what I want to ask about is, when you were trying to get treatment, you mentioned that there was, like, genetically, you've already know that there's some women in your family who have endometriosis, and there's a huge link in general where if your mother or your sister has endometriosis, that's already a sign that you could potentially have it. So despite you having some awareness about this, what were some of the barriers you faced while trying to get diagnosed?
So the barriers, yani in relation to the general idea when it comes to Egypt, they are pretty much structural, intersectional at the same time. Because three things: age, which I think is common in most countries, class, but also marital status really, really, really yani plays a huge role in getting the access and getting to convince the parents to take a girl who is a teenager or even in their early 20s to go to a specialist or even a general gynecologist because of pain. And like for young girls, pain is often explained as becoming a woman. I have been told this is a fertility marker, you're going to become a rabbit. The more the pain, they created the sense in my head that is this kind of chart. The more pain, the more likely I am to get pregnant fast. That's what made me power through. I hope this is a good thing. Somehow it translated into a normal thing, but also a positive thing.
Yeah.
And also in relation to marital status, there's a fertility trap. Yani you are not taken seriously, whether even if you're married and you check the box socially that you are accepted in this clinic because you are married. It is more likely than not that the entire conversation would be about having a baby. Yani that's just it, and that clock is ticking. And when would you stop your hormone therapy and start being off contraceptive to just get it kida over with before your late 30s? That's been my and a lot of other women's experiences, even with things that are much more minor and much less chronic than endometriosis. Yani it can be just a functional cyst that's a bit complicated and needs to be removed. We're like, yeah, we have to do it now because in 6 months you can try and get pregnant because by then you'll be 28, and that's just a big taboo. You're turning 30 and you haven't had children. The third thing I wanted to talk about is class. So in Egypt, public healthcare is quite weak. Yani in all ways and forms. So weak might be an understatement, but we don't know where the public healthcare is. And even public healthcare is not free. Yani you cannot call public healthcare in Egypt free. It is not. It is expensive for an average yani gaining or an average person with an average salary being as I think the minimum wage here is $140 a month. But yeah, it's still expensive to go seek any kind of medical help. But even people of the across class, diagnosis is expensive. I heard doctors taking $100 for a 10-minute appointment now, and these are like the well-known specialists who work precisely on endometriosis. Laparoscopies and MRIs are now luxuries. Yani they're not something that you can think of كده. Now it's $3,000 a surgery. And most women I talk to have been through multiple surgeries from 2 to 4. That's the average. And some of them are in debt to banks and friends and take loans and are struggling to cover a like $10,000 fee in the span of 5 years, sorry, to get 3 to 4 surgeries. So yeah, these are the things that have to do with structural barriers. I also want to go back to your question about me being, as you called it in the beginning of the webinar, a textbook case of endometriosis.
Yeah.
I had my period at 10 years old. The first gyno I've ever went to, I was 10 because I had bleeding. يعني bleeding is the right word. Just going through heavy periods. My mom, sister, aunt, and grandmother have endometriosis, have chocolate cysts. But for some reason, there was this, for them or for their times, doctors really separated chocolate cysts from endometriosis. I'm
Yes.
really not sure why. I really need to interview them, which is part of my research as well. And you have a chocolate cyst, we're going to go in and remove it and get you on contraceptive till you want to have a child and you're okay. While chocolate cysts are a big sign of endometriosis type 4, even if we're
Yeah.
talking types about which we want to dismantle and really look at, يعني for the medical system, it's type 4. So why am I not treated as type 4 with the cyst that is يعني 6 centimeters showing on every imaging I do? Yeah, even though I am يعني very clearly having trouble when it comes to my periods or pain, chronic pelvic pain, very intense nerve sensitivity. يعني a lot of the things that even Dr. Christo talked about, I'm like, check. I was never treated as an endometriosis patient, even in Egypt. I got diagnosed in Lebanon.
Yeah.
Although I was a very adamant gynecology clinic goer. يعني I was on schedule. I'm there every other month. And then I ended up going alone, which also takes us back to the barriers, the gaze of women in the clinic and the assistants and the doctor himself. And they're like, why is this 20-year-old here hanging out alone? I'm not okay.
No, it's even there's just this silent agreement that, as you mentioned, pain is something women should kind of have to just learn to push through. So that's just something that's always been there in the background. But what I want to talk about is because I know on a national level it's going to be a very long time until this is fixed. What I'm hoping to discuss is what people can do in their own small little ways. I know that some of the people in the audience, they, are hoping to have like their own startups or their own nonprofits or their own businesses where they work with women. What are some workplace accommodations they can keep in mind? How can they be mindful of working with women who have chronic pain?
يعني I would love to dream, but I
Yeah.
will get my information from what I heard from the women I talked to. I was blessed to have my actual professional career start in 2020. So it was COVID. I was writing my master's degree. So I have actually almost never had an office job. So I was always a person, a consultant. I sign a contract. I have deadlines. I meet them because I can work at 4 a.m., but you can find me at 10 a.m. just having a flare up or literally flat. No, I'm not there. My brain fog is not working. So from the women I talk to, for education, I think yani, clinics in schools need to understand what endometriosis is because they're the first point they personally go to. No, I had a flare up at school, so I went to the nurse. She put me in the bed in her office and then sent me home or called someone to come get me. But there's no even conversation. Yani, with this nurse, we're with this doctor that exists in the clinics that are on campuses. The parents do not have a conversation with them. They're like, yeah, she was tired today. And then they find out she has her period, or she just started her period, or she's having pelvic pain, and like, yeah, this is just a cold, or this is just your intestines from all the chips you eat, or whatever. But if there is awareness for the people we call the first line of support, this is the first person that saw me in this pain, I think that would help a lot. And when it comes to the workplace, most women really, really, really advocated for work from home. I think COVID has proven that work can be done from home. We are all home right now. And we're having a very important conversation that is multidisciplinary, continent-wide, across countries. Yeah, we're all here, right? But I think this just understanding of that work can be done even if I don't have to get stuck on a desk 9 to 5, and sitting for a long time hurts them, standing for a long time hurts them, having a flare up in the middle of the office in front of their colleagues really embarrasses them. They are framed in a way that is lazy, or that is, they're just not believed. But if there's just this sense that, okay, if I have this kind of issue that is an invisible disability, you need to accommodate me. And my question is not, please give me sick leave and I will not show up. Just let me show up differently. Just let me show up differently. That's all I need. But I think, yes, for me, most women have had their issues since they were in school. Schools are a very, very, very good example of the first people who firsthand experience girls having terrible pains.
Yeah.
And then this channel needs to translate to, okay, here is your daughter. She is going through this. This is potentially this. I know it's a bit early, but it's very common. Even have pamphlets in schools, kida, probably that's what she has. They will be very dismissive, the parents, in the beginning. The last person they would take her to is a gynecologist, but the name will just ring. Maybe the father would look it up, the mother would look it up. They'll think about themselves. Maybe the mother has it, aslan, like in my case. But I come from a family where every generation literally deals with it so differently. Even me and my sister is just 4 years older than I am. And she's like, I don't have anything. I'm fine. I have a baby, so that's okay.
No, I
So
like what you mentioned as well about it's about showing up differently. It's a lot of people are dealing with these things silently. Some of the people listening in, they might not have endometriosis specifically. They might not even have a gynecologic disorder. It could be fibromyalgia, it could be chronic fatigue syndrome, it could be migraines, which is very common with women. A lot of people are silently dealing with stuff. So we are blessed to at least have technology, which isn't always the best thing, but in terms of someone with health technology and the ability to work from home or a hybrid environment, that's great. So if your job is a type where you can do that, which many are these days, it's something that should be adopted more. And in an educational context, even if it's going to take some time for people to be fully on board with what endometriosis is, just having the name ring in the background, the same way we know what diabetes is, the same way we know what migraines are, just to have it in like the public lexicon, the vocabulary is a very important first step. And I think what you mentioned as well is something, a lot of it probably rings true with our next panelist, Elsie Wandera. She has, I've been following her work with the Endometriosis Foundation of Kenya, and I think you guys have a lot in common, and she's going to be able to expand on some of that. This being an activist it's a lot of common factors you see across the continent and across the world. So, Elsie, I would love to learn more about you and the work you're doing with the Endometriosis Foundation of Kenya. So, just, feel free to introduce yourself and how you started with your journey with endometriosis.
Thank you very much, and it's a pleasure to meet fellow activists and fellow women with lived experience, and sending you yellow hugs. Right. So my name is Elsie Wandera, and I am based in Nairobi, Kenya. Just for context, I'm 45 years old, and I've had 4 surgeries. And I am currently in surgical menopause following the loss of both my ovaries as a result of the disease progression. I did not have any children. I was married and divorced. So the thing that I miss my periods. I miss being a girl, but I don't miss the pain. So I founded the Endometriosis Foundation of Kenya in 2015. It was out of a personal place of one, pain and also frustration. I had endometriosis myself, and of course, spent about 13 years not having a name for what I was experiencing. And when I finally received a definitive diagnosis, which was at the age of 26, I realized that the silence around me wasn't coincidental. And I think so hey, I'm not sure. I might be butchering your name in the process. Forgive me. What she was talking about really resonated with me. There was no community, no information in accessible language, and really no pathway that felt designed for women like me, navigating, especially the Kenyan healthcare system, right? So the Endometriosis Foundation of Kenya grew from that gap, which is the belief that no woman should have to decode her own suffering alone. And that's also what led to the start of the Spread the Yellow, which is our community awareness campaign. As you all know, yellow is the color of endometriosis awareness globally. And so through the Spread the Yellow, so we take education directly to communities, universities, workplaces, faith spaces, because we know that diagnosis journeys often begin long before a woman ever reaches a clinic. So they begin with a mother, a teacher, a colleague, or a friend who either normalizes the pain or recognizes that something is wrong. And so the goal for us is we want to build a society where the second response is far more common than the first one.
Okay, no, this really does feel incredibly important to know because you mentioned a lot of practical, tangible help. Because that's what happens when you're dealing with endometriosis. A lot of the stuff can feel like, well, thank you for, like, even now I'm talking about Endometriosis Awareness Month, but people who have endometriosis deal with it. It's a lifelong thing. It's not a month-long thing, and it's not just a webinar. It's affecting
Correct.
them long term.
Yeah.
I know that a lot of our listeners are either in Kenya or in East Africa, so they might be able to get to Kenya for treatment. Do you have any means of, or do you suggest to patients where they can find specialists, where they can find pelvic physiotherapists? Could you tell us more about that?
Yes, we do. And because, we recognize that there's a barrier for women to first even get diagnosed, right? So we have a community, and we also use our social media channels, of course, to do that awareness. And so for everyone who reaches out to us and asks for contacts of a doctor or a pelvic floor therapist, and these are things we are learning and discovering much later on this path. We do direct them because we recognize that one, there's a significant skill gap around endometriosis recognition at primary care level in Kenya, especially. And so it's important that, we direct them to the right doctors with the right training and experience and understanding, and the eye to be able to see and hear also, not only the eye, but someone who will be able to listen to you from a place of empathy, like Dr. Christo actually talked about. And our Telegram group also sits with that same gynecologist who's able to then answer questions or any concerns that women will raise while we're in the community.
Okay, no, that's something that they can really talk about then directly. What you try to do is to, I think it also goes back to what the doctor said earlier, is to not use just a one size approach, is to kind of tailor it according to what they're
Correct.
dealing with. So
Correct.
yeah, and you mentioned as part of your campaign, so can you tell me more about this campaign? Is this something you do during the month or about Spread the Yellow? Uh, yeah, just more about, is that something you're still continuing to do? Do you have a webinar or any activities coming up that you want us to know about?
Yeah, so we, like you said earlier, Lara, for us, this month of March is not when our activities happen. You
Yeah.
know, we live it every day and we continue to talk about it every day. So we usually host learning sessions and we host communities, webinars. We have also sessions where we get together to do physical activities and just just away from the medical kind of and the tech clinical kind of activities where a woman can actually get to just be herself and express herself. So this month, so last month that was one of the activities we did, but this month we actually have the privilege of screening the Below the Belt film, which is a film that really just showcases the systemic issues and the barriers that a lot of us women are going through and experiencing. And so we'll have like a 2-hour session where we'll watch the film and then have a discussion with a clinician, Dr. Charles Muteshi, in the room to just help the women just debunk and process what they've just watched and experienced.
Okay, thank you so much. And the last question I want to ask for you is you mentioned that as part of what you're doing is, of course, there's a lot of work goes into it, just to keep it lightly. It's a lot of work. So how do you manage that along, or what can you suggest to activists on how to manage some of the effects of endometriosis alongside their activism so that they're not burned out? If you have any suggestions, I'm sure many would appreciate that as well.
Absolutely. I've learned to say no. Like, no is like a word that I am using, especially in my 40s now. Like, I'm really actively using that. It's okay to say no. I'm not able to come into work today. It's okay to say no. I can't show up for this engagement. If you invite me for a speaking opportunity and I experience a flare, and I'm not able to show up, it's okay for me to say no. It's okay for me to say no to social gatherings and even, the closest circles with our family. I think that's the place where we need to do a lot of self-advocacy, and just make sure that people are aware of what you're going through. So it's not necessarily to turn people down and say, no, I'm not going to do anything and I don't want to do anything. But the other thing is also listening to your body. So I wouldn't encourage, just intense physical activities, because I know that for a lot of women, there are a lot of triggers, when they do those kind of intense exercises. So I encourage things like, mobility exercises, stretches, yoga. There's nothing wrong with just making sure that at least you're stretching your body, and getting that energy and from whatever gives you energy. So, and just love yourself. I think one of the things for me, which I had to really reframe, was what I called this, like how I hated myself and how I began just completely sitting in a victim mentality and telling myself I am nothing because I don't have children, because of all the labels that society gives us. So I'm continuously sick, or opportunities at work I'm going to miss out just because of this illness. I am learning to thank my body for carrying me through all these years. You know how difficult it is to live with this condition that just shows up in just different ways, has a burden on my mental health, right? So I remember I was diagnosed with depression in 2020, and I didn't realize it was because of the lowering levels of my estrogen, because estrogen plays such a critical role. And so I would encourage us, seek that multidisciplinary care. So it's not only your gynecologist. If you need to speak to a therapist, do it, go for it. If you need to seek a pain specialist, go for it. Pelvic floor therapist, whatever help you need, go for it, because you cannot show up for people when you're not showing up for yourself. And you need to pour from a place of being full rather than being empty. Yeah.
Thank you so much, Chelsea. I think that was very beautiful because it just goes back to trying to find the balance. And like you said, you can't pour from an empty cup. You need to take care of yourself first before expecting things to just fall into place. If you need to work, you can work in microbursts. You don't have to work, just force yourself to push through the pain. You can learn to say no to certain social situations and to really stand up for yourself. And that could be the one silver lining. With this condition, I know that's hard to find, but if there's something to take away from that, it's how to learn to advocate for yourself, not just in healthcare settings, but in your own life, because that's a skill that is transferable to other areas in your life. So that's
Mhm.
something that you can take away from dealing with this or really any sort of chronic condition. And I
Correct.
do want to circle back to Sahila because, as I mentioned earlier, there are some similarities with what a lot of activists are dealing with. But before leaving or before ending this webinar today, I do want to just ask her with what activities or what things she's currently focusing on as part of her endometriosis activism, because I know she has some exciting things in the pipeline. So please feel free to share, Sahila.
Hi. I was on leave till September from my PhD project and studies, but March is Endometriosis Awareness Month, so the field just absorbed me again.
Yeah.
And it's been 13 days, Laura, since
Yeah.
I got back to the field. So
Oh
what we're
God.
doing is yeah, exactly. We're doing
It's a lot
focus
of work
groups
in a
in
short
13
span of
days.
time.
Yeah, so what I'm doing is my project is ethnography based, but I'm trying to look at something called patchwork ethnography. And patchwork ethnography is where you are mindful of the limitations that would allow you to do traditional anthropology, where you go spend time, if not months and years, in the spaces you want to talk about and look at and research. So what I'm doing is rather a mix between the online sphere being a site and the offline sphere being another side for both women and healthcare professionals, because women are much more comfortable talking in their own space with a headphone on whenever they feel like it, or it's private enough for them to speak, rather than me spending months and months in doctors' clinics where women are not in the mood, very simply, to talk to me.
Yeah.
And they completely understand. If I was them, I wouldn't have talked to me as well. So what I'm doing is I'm trying to create this support group on WhatsApp. We have 85 people now. Thank you.
Yeah.
And I'm also trying to collaborate with another woman called Mai, who has a Facebook one, which with much more women. But the ones that engage on the WhatsApp group are so impressive because it's so organic and natural, where they're just like khalas, they're friends, they're talking every single day. Any question that crosses their mind is there. They're giving each other recommendations. And even if you ask Laura, I just told her I archived the chat. Like, I don't want to influence
Yeah.
anything of what's going on there. I just answer when it's really, yani, I can help, or when it's
Yeah.
absolutely necessary, no, I have to intervene right now. Like when they're having a fight, which happened yesterday, there was very much tension on the group where I had to be like, if this monster was not that big, we would have all been treated. If one size fits all, we would have all been treated. If something doesn't work for all of us, we would have all avoided it. Yani, none of the group members or us or Elsie or the doctor or anyone in this
Mhm.
world can tell you that this is the gold standard, yani, for treatment or for dealing with the pain at least. But back to
Exactly.
your question, another thing I'm doing is that I am hosting a screening for a film called I Told You So. It's a short film that is award-winning. It's in Arabic, but also has very proper subtitles in English. And by coincidence, I interviewed the director back in May. And by coincidence, she is coming back to Egypt, although she doesn't live here anymore today. So we're having the screening on the 28th with a Q&A and an open discussion to
That's
follow.
great.
Yeah.
And just on the note of Q&A, because what we've been talking about now is how everyone's experiences feel so common right across the continent, no matter like the country. We're not divided by borders with a lot of the things we're dealing with. And I am seeing a lot of activity, on the chat and all over of people listening to this, and I think that they see themselves. So if anyone listening currently has any questions that they have for Elsie or for Sohaila to kind of understand how to manage the condition better or where they can seek support, feel free to ask us and we'll be happy to help. Okay, no, so from what I'm seeing happening is a lot of people are adding themselves in their own groups in the chat, or they're trying to get to know each other. So that seems to be what's happening over here. And what I just want to leave everyone with then is to just understand how they can connect with one another, and they can reach out to, well, to Sahila, or to, if you're in North Africa and you want to see more about the resources in the continent, or if you're in Kenya, Elsie mentioned that she works one-to-one with specialists. So just to avoid going down that, just going down the path of looking for doctors or looking for physiotherapists and not knowing where to begin, just message the Endometriosis Foundation of Kenya if you're in Kenya. The way that I found Dr. Beneka, Dr. Crystal Beneka, I found him through a support group for endometriosis in South Africa. So just because I don't want anyone to feel like they're being overloaded with information, because chronic pain is, again, a very sensitive, complex thing, what I recommend is to reach out to the support groups in your country or in your area. If you're in East Africa and your country doesn't have direct endometriosis support groups, try to reach out to support groups in nearby countries such as Kenya, for instance. So Facebook is a good way to find this. Instagram, forums, just kind of give yourself some space to do research. But as the doctor mentioned earlier, it can be a bit overwhelming, not knowing where to begin. So the best thing to do is to simply ask, who are the best specialists in my country once you get to the support group? Then to do your own research so that you have your questions prepared once you visit the doctor, and to ask what sort of conservative treatments you can do, whether or not you're going to do the surgery, what treatments you can do alongside, such as pelvic physiotherapy. I think that's something both Elsie and the doctor mentioned can really help with day-to-day pain. Just the idea of managing to make your quality of life better, because that's what matters at the end of the day, is getting through each day feeling like it's easier and feeling like you have a system. So yeah, just reach out to support groups, reach out to us. There are the emails of Sahila, she mentioned hers, and if you need anyone else's contact information, you can reach out to Africans Rising, and I'll be happy to direct people to any support groups. So yeah, thank you so much. This has been great. And I feel like I
Yes.
really, yeah.
No, I was just saying, I'm just going to put on in the chat the Africans Rising email that they can
Yeah.
use if you're trying to reach out to any of them, or if you're facing any difficulties, and we can direct. But also, we've had like so many amazing people join us on the call, so it's also always good to hear from anyone. So if there's anyone in the audience who would like to speak, just say something short that doesn't make this about those of us on this other side. It'd be amazing. You can raise your hand and we can let you speak. So if anyone wants to share, it could be a personal experience, or maybe wants to just get clarification on anything specific. We can use the next 1 minute to take that, just making sure that there's not someone like that is not out there.
Yes.
I think in our controls, if you've joined in the webinar version, at the bottom right, you should see the option that allows you raise your hand if you would like to speak, and then we can promote you and just have you share something. So just giving this last minute for that in case there's anybody. But if not, okay. All right, I don't see that anybody is indicating. But if not, I would like to thank so much our speakers for being here today. It was a wonderful conversation. I was looking forward to it myself because I had so much to learn. And as a movement, it felt different, to have these kinds of conversations. And I was happy that we had you all on board. Thank you for sharing your stories. Thank you for enlightening us. And we're hoping that this would not be the last of such conversations. Definitely
Yes.
looking forward to other opportunities to engage with you. And yeah, so thank you so much. Yeah.
Thank you, everyone. This has been great, really.
All right. Bye-bye.
Thank you.
Bye-bye.
Bye.